Hey guys, today I'm going to be sharing my case study with you. So my case study is actually about my husband. This happened on May 28th in 2007. At the time, he was a 13-year-old male. He sustained an injury to his left knee during a boating accident at San Carlos Lake. A little bit of backstory. Briefly, I'll tell you the story. My husband was riding a jet ski when he hit a wave and was thrown from the jet ski, and unfortunately a boat didn't see him in the water, and as he saw the boat coming to him, he tried to shove himself under the water or remove his jacket or do anything he could to get out of the way, and he wasn't able to get out of the way. He decided to lay back so that it wouldn't hit him in the head, thank goodness, and it did hit his knee. It wasn't the propeller, it was just the blunt force from the tip of the boat that hit his knee, but it did splay his knee open pretty badly. He came to a few minutes later and they realized that his knee was, splayed open. You could see bone fragments, you could see soft tissue in there. So they lifted him into the boat, took him back to camp where they duct taped him up and sent him off to the hospital. The nearest hospital was about 30 minutes away, 45 minutes away maybe, Mount Graham Regional Medical Center. It's in our hometown of Safford. He was there with his grandpa, and at the time it's a really small hospital, mind you. The injury was drained and sutured up. Whenever he was sent home, his grandpa said, "Hold up, you're not even going to do some x-rays?" So they got some x-rays done. Unfortunately, I don't know how this mix-up happened, but the x-rays were misread the first time. The x-rays showed the first time a damage to the growth plate, his epiphyseal plate on his left knee. So the fear now is that, okay, he's not going to grow from his left leg, but his right leg is going to continue to grow. He's going to grow crooked. So the solution here is to also damage the right growth plate. They would do that under anesthesia, and there was not a great surgical center at the time in Mount Graham Regional Medical Center. So they decided between the growth plate injury and the fear of sepsis from the nasty lake water being in his wound, they needed to send him to TMC in Tucson. So he is sent by ambulance to TMC in Tucson. At TMC in Tucson, the doctor there decides that he doesn't trust that first set of images and he wants a second set of images. So the second set of images show a comminuted fracture in his left knee, left patella. This is what a comminuted fracture would look like. A comminuted fracture just means that there's more than 3 pieces in the fracture. These are not real images. This is a representative image. I wasn't able to get his real images. But like I said, this is a comminuted fracture. There's 1, 2, 3, 4 pieces that I see, but they're pointing to 3 here. And an anatomical picture from our book here. In TMC in Tucson, like I said, they took these pictures. It showed a comminuted fracture, and his laceration at this point is like 4 or 5 inches vertically on his left knee. The images that were required here, the patient's a trauma patient, his knee is in a splint. So the first image that would need to be taken would be an AP, that would just be a regular AP. A lateral, which in a lateral you're going to have to do a cross table lateral, as the patient's not going to be able to bend their knee to the side for the lateral. And depending on your hospital's protocol, maybe an oblique, a medial oblique, and that oblique would have to be faked by the tube angle. The patient's not going to be able to roll their leg in themselves. He says he also remembers them doing a sunrise image, which would look similar to this. The sunrise projection is actually the tangential projection in the Settegast method, according to our Merrill's book. The danger with this is that if there are fractured fragments, those could possibly be displaced and cause some damage to tissues around the wound. So this is what the sunrise method would look like. The patient would hold the IR above their knee, and there would be an angle upwards, phallic, just skimming that patella, and this is what the image would come out looking like, only of course with the image, or with the damage with the damage to the knee, there would be multiple fragments there. The knee should be kept in the splint and should not be attempted to bend into the sunrise image projection position until it is cleared by the physician, just like I said, for the danger of those fragments being displaced. The course of treatment, I think this is pretty cool. I actually have his medical records here that I was able to find, the dictation from the surgeon after surgery. This is basically what I'm going to read is here, so I have it there for you to view as well. So that the sutures were removed and copious amounts of irrigation with bacitracin was then used the superomedial quadrant of the patella and free loose pieces of the bone were removed. The fractured edges were then reduced and held together with a bone reduction clamp. 2 guide wires were then introduced through the medial aspect of the patella across the fractured fragments into the main fragment. Another guide pin was then introduced through the medial side into the main fragment. AP and lateral fluoroscopic views confirmed good position of these pins and good reduction of the fracture. I thought that was cool just because it tells us exactly what happened in the operating room, as well as confirms that fluoroscopy was used, AP and lateral, to confirm those pins were in a good position. This is another representative image I have of what those pins may have looked like at the time. This is just a super creative little picture that I put together just to kind of, wrap your head around what the physician said here. He's saying that there were fragments that were removed by vacuum. That's what these are representing here. They said that there were 2 main fragments on the superomedial border of the patella that were able to be pinned together. So that's what these are representing here. Probably wasn't a perfect circle. And this here I've drawn as a representation of what his patella now looks like. You can actually still feel he has this notch in his superolateral border in the top outside border of his patella. There's still a little notch cut out that you can feel if you kind of rub in there. It's grown back a little bit, but not all the way. The outcome of this patient, of course, they were worried about the sepsis, so they did keep him and hold him in the hospital for about 72 hours afterwards to administer some antibiotics. And he also needed physical therapy for about 3 to 5 months. He's not sure exactly what the time frame was. Physical therapy would just be needed to strengthen the knee, to decrease the stiffness, and to increase the range of motion there. And lastly, he does still have a couple of complications regarding or resulting from this injury. The injury happened in the summer, so coming that fall, he returned to playing football. And maybe it was too soon, who knows, but he started to compensate with his right leg for that injury in his left knee, and that caused, over the course of the next 5 years until he was a senior in high school, his right knee popped out of place, he estimates maybe a dozen times. That being said, whenever he was a senior in 2012, he had to have a ligament moved, and it kind of cradles now the outside of his patella. That happened in a surgery in 2012. It cradles the outside of that patella in his right knee just to make sure that it doesn't continue to pop out. But they do estimate that he'll have to have probably double knee replacements by the time he's maybe 40 or 50. So that's a bummer, but that is my case study.